This is an ataxia case, so I'm going to give you the differential diagnosis of ataxia. The differential diagnosis can be a very long list, but to make it easy, I would like to divide it into hereditary ataxia and acquired ataxia. So at first, hereditary or inborn ataxia can be divided into autosomal dominant ataxia, autosomal recessive ataxia, mitochondrial disorders with ataxia, and inborn error of metabolism. One of the common autosomal dominant ataxia is spinocerebellar ataxia, and autosomal recessive ataxias are Friedreich's ataxia, ataxia telangiectasia, ataxia with oculomotor apraxia type 1, A-beta lipoproteinemia, and ataxia with vitamin E deficiency. Inborn error of metabolism are hexoaminidase A or B deficiency, adrenoleukodystrophy, and Wilson's disease. Mitochondrial disorders with ataxia are NARP or NARP, neuropathy ataxia and retinitis pigmentosa, MELAS, mitochondrial encephalopathy with lactic acidosis and stroke-like episodes, and MRF, myoclonic epilepsy with red ragged fibers. The acquired ataxias are due to toxic or alcohol misuse, drugs such as phenytoin or lithium toxicity, vascular events like intracranial hemorrhage or ischemic stroke, inflammatory events like demyelination, neoplastic causes like metastatic brain tumor, especially in the cerebellar region, primary brain tumors, and paraneoplastic syndromes like anti-WHO, anti-EO, etc. Infectious or post-infectious causes are viral cerebralitis, subacute sclerosing panencephalitis, HIV infection, Miller-Fisher syndrome, prion-induced disease like sporadic or variant Creutzfeldt-Jakob disease, structural abnormalities such as arteriovenous malformation in the brain, basilar invagination occurs in Paget's disease, and obviously Arnold-Chiari malformation. Nutritional causes are vitamin E deficiency, thiamine deficiency, for example, Wernicke's encephalopathy, and in celiac disease. Finally, one of the important endocrine cause is T4 deficiency. Now, if you get a case of ataxia in station 2, for example, an elderly man complaining of abnormal gait and recurrent falls, then obviously you cannot exclude all the causes of ataxia because the list is quite long and you won't have much time to exclude all differential diagnoses. So first thing first, you should introduce yourself, confirm your identity, confirm patient's identity, tell him the agenda of today's meeting, then ask him how much he already knows about his condition. Does he want anybody else to be present in this discussion? You can also tell him that you can take some notes during the discussion, but these notes would be highly confidential. We would start our history taking by asking him the onset of gait abnormality. When did it start? Exactly, did it start suddenly or gradually? Is it all the time or coming on and off? Is there anything that aggravates this problem or relieves this problem? Since in the station 2 you cannot examine the patient, so you must ask him about the specific type of gait abnormality. We know there are many types of gaits like Parkinsonian gait, hemiplegic gait, spastic gait, high stepping gait, waddling gait, and finally ataxic gait. Since this patient complained of gait abnormality, he did not complain of ataxia, so he can have any one of these gait. So ask him, do you shuffle your feet along the ground? Do you have a narrow step gait to exclude Parkinsonian gait? Do you drag your one foot at one side to exclude hemiplegic gait? Do you drag both feet at the side to exclude spastic gait? Do you lift your feet high off the ground to exclude high stepping gait commonly seen in peripheral neuropathy? Do you have a waddling gait, waddling from side to side when you walk, to exclude waddling gait? Do you feel imbalance while you are walking and you have a wide base gait, your feet are very wide from each other, to exclude cerebellar ataxic gait? Dear candidates, I would like to tell you the ataxic gait can be due to cerebellar pathology, cerebellar ataxic gait, or due to peripheral sensory problem, sensory ataxia. So if someone has cerebellar ataxia, he would have broad-based gait and he would have imbalance as well. The gait would somewhat look like a gait of a 11-month-old baby who can walk few steps but still hasn't mastered the skill. On the other hand, if someone has sensory ataxia, then he would show high stepping gait and he would lose his balance if his eyes are closed. To exclude central causes of ataxia, we would ask if there is any visual disturbance, altered speech, shaking of hands and feet, any weakness, altered sensation, headache, seizure, any history of stroke or mini stroke, any relevant family history, to exclude the hereditary cause of ataxia. To exclude peripheral causes of ataxia, we can ask if there is any pins or needles in the feet or hands, any history of falling down when you close your eyes. When you walk, do you feel like walking on a piece of cotton? Do you have any weakness or heaviness in your feet? Then you can start to review each systems. Some general symptoms may be asked. Do you have any fatigue, any loss of body weight, or any gain of body weight? If yes, how many kgs, in how many days? Any lumps or bumps, any fever, chills, rigor? Then from pulmonary symptoms, any cough, phlegm, noisy chest, any history of asthma, any bleeding from nose. From CNS, you have already asked some questions, but you can also add a few here. Do you have any difficulty in initiating movement, any rigidity, any loss of arm swing while walking, shaking of one or both hands, or any change in handwriting, to exclude Parkinson's disease, any forgetfulness, loss of concentration, change in behavior, etc., to exclude frontal lobe lesion. Then from CVS, you can ask about chest pain, racing or pacing of heart, leg swelling, shortness of breath. From genitourinary system, you can ask about the water work, amount, color, frequency, any frothy urine, any pain during urination, water work. Then from musculoskeletal system, any joint pain, any joint swelling, any joint stiffness. You can also take some sexual history. Are you sexually active? How many partners do you have? If the patient is female, ask about menstrual history, pregnancy, use of oral contraceptive pill. From hematology, do you have any bleeding from any body orifice, any bleeding under the skin? You should also take traveling history, medical history, which would include prior medical admissions, any comorbid diseases like diabetes, hypertension, heart disease, Diabetes is important because it is a cause of peripheral neuropathy and may cause sensory ataxia. Surgical history is also important. Any previous surgical operation, blood transfusion, dental procedure, tattooing, piercing, needle sharing. Drug history is important because I told you that some drugs like lithium and phenytoin can cause ataxia. So you can ask his drug history. Do you take any over-the-counter medication, any herbal medication? Do you have any drug allergy? Always take social history. What do you do for living? Is your symptoms affecting your occupational or social or family life? Do you need any support? Do you drink? Do you smoke? Do you need any financial support? With whom do you live? Do you need a caregiver? Do you drive, etc.? And then summarize the positive findings from the discussion and finally ask for his concerns. The patient may ask you, why am I having this type of abnormal gait? Then answer him according to the information gathered in this discussion. If it is suggestive of peripheral neuropathy, then explain it in a layman's term without using any medical jargon. If it is due to any hereditary condition or any cerebellar pathology, for example cerebellar stroke, then explain that. So let's consider this patient has peripheral neuropathy due to diabetes and you gathered this information from today's discussion. So you can tell him that from this discussion I think you have a condition called peripheral neuropathy. Don't bother about the terminology. I'm going to explain it to you. It happened due to your long-standing diabetes mellitus, which was probably uncontrolled, and it caused your nerve damage. That's why you are having this abnormal gait, and you are also getting some abnormal sensation over your feet. So we are going to attach you with our multidisciplinary team, including an endocrinologist, I mean hormone doctor, and many other professionals. We would test your blood for diabetes and also give you some medications, perhaps insulin if the endocrinologist find it suitable. Good control of diabetes is absolutely necessary for your condition. Diabetes may cause other problems as well. For example, problems in your vision, in your kidney. So we are also going to test these. The examiner may ask you about the differential diagnosis of ataxia, which I covered at the beginning of this podcast. And he may also ask you how would you investigate this patient and finally treat this patient. So the investigation and treatment would depend on the diagnosis. If it is peripheral neuropathy, then I already told you that you have to test his blood for diabetes. And you can also do EMG and nerve conduction study. You can also do a CSF analysis if you believe the peripheral neuropathy is due to Guillain-Barré syndrome. But if it is due to other problems like brain tumor, then obviously you are not going to do nerve conduction study. In this case, you are going to do the MRI of head or perhaps PET scan down the line.